making her return to the show. It's been a little while since you've been on.
A little bit. Where's my theme music,
Jenny
buddy?
is here. We need to find something for you.
Seriously.
We haven't been on lately, so we haven't...
Well, maybe that's because you haven't been nice enough to give me any music to come on.
Oh, I see how it works.
Bribery goes a long way with me, you know?
Yes. Well, we have a couple of wonderful guests with us for the first hour. Did you want to introduce these gentlemen? Or
Actually, I'd love to. Please welcome, which I'm really happy to have, Dr. Ngo and Dr. Sanchez, both from Pain Specialty Group, painspecialtygroup.com. They're joining us today to talk about pain care in the state of New Hampshire, some of the trials and tribulations people go through, and some of the state-of-the-art available treatments that are out there today so people can get pain care here in the great state of New Hampshire, not have to travel to Boston to get your care. You can do it right in your backyard. I'd love to hear from each of you as far as, of course, Dr. Sanchez, why did you start your practice? And Dr. Ngo, please follow suit with a little bit about you as well.
Okay, great. I'll let Dr. Sanchez start. Yeah.
Sure. I came to the Exeter, Portsmouth area about 32 years ago. My background is anesthesiology, and I did my training in Canada. The reason I came to the States is because there were some issues with the healthcare in Canada with socialized medicine that I did not particularly agree with. And secondly, because there was, the field of pain medicine, it was just not as well developed as it is in the United States. And my interest right from the beginning of my training was in pain. So coming to the area was for me a difficult move because, we had to move away from family and friends. And but when I look back, I think it's probably the best thing that I have been able to do, because I was able to build up a very successful pain practice in the area. So the field of pain medicine has changed tremendously over the course of the last 40 years. And I have been very fortunate that for the last 30, I have been part of it. It is certainly an area that is changing very much, and we all know and are familiar with what they call the opioid epidemic, which is, I have my personal views about that, but we can probably talk about that later on. But I think that opioid epidemic, quote unquote, is something that has been to the detriment of a large majority of patients that are in real need of pain management, to the point that today, a large number of those patients that are seen in pain practices are treated like criminals. I think we heard a little while today. One of my patients that I saw this afternoon made exactly that comment to me.
Mm-hmm. Yeah.
That I don't go to that practice anymore because they make me feel like criminal, and I think that is wrong. There is certainly a need for some proper and comprehensive care of pain with narcotics, and I think narcotics play a very important role. But over the course of the years, there has been a tremendous shift in looking at pain management from different modalities of treatment. And, I am very happy that Dr. Ngo has joined my practice, because he's become like the lightning rod in bringing in some new technology to the area with some very innovative treatments that I think are going to be revolutionizing the field of pain medicine. I am ecstatic that Dr. Ngo has joined my practice, and I cannot tell you how happy I am, and my patients are also very, very happy.
I think Jenny would second that as well.
Big time. As a patient who actually has been in the situation of being treated like a criminal, and I was a 911 EMT. I was somebody got up in the middle of the night to run out. To be treated that way is so dehumanizing that one of the first times I came to your office, and for full public review, I am a patient. And I speak freely and ask my doctors to please speak freely about my care in hopes that other pain patients like myself don't suffer in silence and go untreated. I wanted to cry practically the first time I came in for a treatment, because you came in with Dr. No, and you both were right there by my side taking care of me, and it wasn't a nurse following an order somewhere. Not that that's a bad thing, but just to how personable you are and how much you made me feel like I'm a patient again. Yes, I'm a breast cancer surviving patient with a really rare disease that stinks, but I deserve to get care, and you guys gave me that. So, I mean, I know from the bottom of my heart, I love it, and I just want to scream it from the rafters, because it's how every patient should be treated. Because I certainly, when I was in the field, wouldn't treat a patient that way. So being on the other end is kind of stinky. Dr. No, tell us a little bit about yourself, because you have one heck of a history.
Well, all I have to say is that, Jenny, you're making me blush on air.
I do that a lot.
Thank goodness we're on radio and not like real. Like, even
You're
though there is a
also,
stream.
well, sorry, buddy,
Yes.
but you're on Comcast cable too. So.
You can pull that mic forward if you need to.
Okay.
Just so you're
Thank
not-
you.
Yeah, there we go.
Yeah. So my history, a little different, Dr. Sanchez, but we do have some crossroads. I did grow up in Canada. I was an immigrant from the Vietnam War. We left the country in '75. Grew up near Toronto, and we rejoined the rest of my mother's side of the family in Southern California when we were able to be accepted for immigration to rejoin the family in '86. I grew up in Southern California, did my training out there. After that, decided to try a job in Las Vegas, and I was there for about almost 10 years. My medical group got bought out, and whatever. And I always tell patients this: whatever happens in Vegas, don't be fooled. It doesn't stay in Vegas. But it was a wild night.
Oh boy.
Yeah, but so I met my wife out there. We had a family, and it pulled me out here. And that's how I ended up out here. So I ended up in Boston, worked at the university for 3 years. One of those years, went back and did a subspecialty training in interventional pain management. And I started looking around at different opportunities. And it just somehow my road and Dr. Sanchez's road crossed. And I just thought it was such a blessing in disguise to be able to join a very well respected, very well practiced gentleman in the pain field that I can learn a lot from, and I've been learning ever since day one that I've been here. It hasn't stopped, and it's been fun.
Mm-hmm.
Yeah,
Outstanding. Yeah. I should mention, if anyone has questions at all for the doctors or any information to share, you can call us at 603-250-6007. 603-250-6007. Also, you can send a text to 617-917-4476. You can tweet me at Matt Connarton or send an email to matt@ipmnation.com. You can also, of course, interact in the Facebook live chat. I see Brian Mackey, Stefan Philbrook is in there, Jenny is in there, of course, and Michael Martineau, who is also here in studio with us. But that's also another way that you can interact with us. And the doctors are going to be here till 5 p.m., so they're here for the first hour. So anything at all, because obviously, when we're talking about pain management, we're talking about an issue that, that affects so many people. Jenny talked about, too, being made to feel like a criminal. And, the government, of course, is kind of butted in and caused a lot of that, unfortunately. But it's an issue that that I care deeply about, because it's affected people whom I love. Not only Jenny, but my mother as well. She broke her back. I think it was 1979. She was in a terrible car accident right here in Manchester on the Emmuskeg Bridge, and so she's lived with chronic pain ever since. She's not in the area; she's in Kenosha, Wisconsin. But but she's been through a lot of that too. In terms of her doctor, who was prescribing something for her, all of a sudden couldn't prescribe anymore. Because he was, the fear was put into him that he was going to, have his practice ruined by the, by the government and whatnot. And
so I'd like to comment.
Yeah, please. Yeah,
just add a comment to this.
Absolutely.
To kind of continue on what Dr. Sanchez was saying, is that we're in a challenging time right now where people are in pain are feeling like they have limited options for treatment.
Yeah.
And I think some of the challenges are because in society, a lot of times pain is marginalized. And if you have pain, you tend to fall back into the shadows of society and you're not at the forefront. Pain is real. Any person can attest to that. And so, and when Dr. Sanchez did mention that opioids is a way to treat pain, I completely agree. And coming from a Boston hospital where opioid prescribing was very shunned upon, and patients were managed in multiple different ways, which we can get into, but it wasn't completely effective. But it was quite effective, but not completely effective, because it is an important element.
Right.
So I just want to say that pain is real, and a lot of us providers do recognize that. And I'm very grateful that I'm working with Dr. Sanchez in a practice that we really do understand and see patients in pain. And that's why, Jenny, when you came to me, and is it okay if I speak
Absolutely.
a little freely?
100%.
I'm honored to have the chance to help you. And I already immediately knew kind of the path we needed to go. And that's why, thank you for giving me a chance to help you live a fulfilling, complete life.
In all honesty, I was to the point after my previous provider suddenly closed and I was abandoned. I was looking at assisted suicide because, quite frankly, I have reflex sympathetic dystrophy, also known as complex regional pain syndrome. It's rare. It's the most painful disease known to modern medicine, and there's no cure. And from my standpoint, I saw no treatment because I was told that opioids and narcotics weren't good. And then losing my access to what was my ketamine infusions at that time left me with a feeling of I have no option unless I let them give me a medication that's going to take me away from who I am, because I had no experience with being on any medications outside of that except for opioids and narcotics combined, which we've talked about, and I'm happy to go into that those weren't even the right meds for me. But my life was being made hell by that. When you guys came in and opened up and found your practice, it literally was a lifesaver for me, because now I'm planning future, and I'm not contemplating death or making sure that my will's all set or my durable power of attorney is all set. These are real things, and it's not because somebody like me has, and I really want to make sure I say this, I do not want to die. I have no suicidal ideations whatsoever. I want to live to be very, very old so I can absolutely drive Maddie crazy for the rest. And anybody else I get to drive nuts. But I refuse to live without dignity. And if I have to live in a bed where I have no life and no dignity, I would rather allow myself to have that choice. And I know that that's a tough subject for a lot of people. And, it's been heavy on the minds of people in my community since the Olympiad Verut passed away in Belgium. That was an extraordinary circumstance. What you're bringing to the table is state-of-the-art treatment. And I'd love for you guys to go into that a little bit more too, because there's more than just a pill in a bottle that can be done to help pain. I know from myself, yes, I have this horrible disease, but everybody was paying attention to that horrible disease. They forgot to look at the rest of me. And in doing so, I think in 5 minutes into my physical exam with Dr. No, and we said, no, wait, you have this other problem going on, this spondylosis, that's causing this pain that we can treat in a different way. And that's actually with a procedural treatment, and I'll let you guys talk about that. But there's more options out there for you as a pain patient. So please call in if you have questions or write in, and I want the doctors to be able to go further with that.
Yeah. This is what you're just saying is something that we see with tremendous frequency among our patients with chronic pain. The fact that I'm not talking about our practice, because our practice really has an emphasis in looking at the patient as a whole, in looking at the patient as an individual.
Yeah.
And we do that because we spend time with our patients. Our practice is not a practice where, we see a patient every 10 minutes and we delegate the care of the patient to a mid-level provider. And we never see the patient again. We don't do that. So the management of the patient in chronic pain is something that, like in your case, you just mentioned you have this spondylosis that can be treated by other means, and that is something that very frequently is overlooked. That there are other medical issues that can be treated by either interventional procedures or different types of nerve blocks, or some of the many other things that we have to our patients in chronic pain to offer. But we try to look at that because in a very large majority of cases, there are procedures, treatments that can be done to alleviate some of the discomfort. Yeah. Chronic pain is, it's incurable. You cannot get rid of chronic pain, but you can make that chronic pain livable. And that is the philosophy of practice, to work with our patients to try to make them learn to live with pain. And that is, something that I think that the majority of the doctors, and I can speak this freely because I have been here long enough, most of the doctors here, because of different circumstances, not because they're bad persons or anything like that, or bad doctors, is that the circumstances do not allow them to spend the time that they need with the patients, because they're part of a large organization that requires them to see 30, 40 patients a day, and they have to.
Yeah.
They don't give the patient the time.
Yeah.
When I first started with a pain care center, I experienced that. I went through three providers inside the first year alone. Year to 2 years alone there. The providers weren't staying because the workload was so horrific. They were constantly cycling through. I never knew who I was going to see.
Yep. That was the place in Merrimack you're talking about?
Merrimack and Concord.
Yeah.
They're one of those multi-places.
Yeah.
And it's very much like you described. You walk in, they listen at the door while you pee in a cup, because of course you might put water in it. So they do that, then they take it and they seal it in front of you in this whole fashion, and you initial and they initial. And when you get through with that, you go to the parole office, the intake nurse, who then wants to see your bottle, count your pills, because of course you're in agony, you're going to divert your pills to somebody else. Said no chronic patient ever. And then you go through this whole system that by the time you actually see the provider, you got maybe 5-10 minutes with them. They give a rubber stamp, they hand it off to a nurse, and the nurse is filling you a prescription. You're just in this terrible merry-go-round of heck. It doesn't provide care, and it doesn't give you any quality of life. It just covers it all up and makes you be quiet.
Right.
Yeah. I just want to add to what Dr. Sanchez was saying about kind of a comprehensive approach to pain care, is that not only is spending time very important for being able to figure out what is going on with the patient, so that we can adjust our offerings or options for care, but two is that element of time builds a bond, and with that bond you then build that sense of trust, and that's where you can start maneuvering around different issues, because pain is not just one issue. Pain can be physical, right? It can be aphysical, which is more something like neuropathic. It can be psychological. It can be just something in the background that affected you many years ago. It could be a chemical imbalance. Who knows, right? And so that little bit of element of time is very important, because that's what gives both sides, because the treatment of pain is not just from the physician to the patient, but it's about, let's get together, let's kind of brainstorm and think about how do we best approach, and how can we best fine-tune and go down to the details of maybe this may be a little bit better. I also want to add just the kind of understanding is that this is a very exciting time for pain medicine right now. Not only do we have very skilled providers with, and just like cars, not all cars are built equally. Like,
tell me about it.
Yeah, certain cars not built like another car.
Yeah.
you can't drive, a Prius through the snow as well as you can with
You
a
trying to
four-wheel
say
drive.
I'm a Prius?
I drive a Prius. That's why I'm telling you that.
Oh no!
Yeah.
I take that back. I take that back.
But what I'm saying is that it's the same with even some providers. And I can tell you, I've learned a lot from Dr. Sanchez and some of the pearls and the little techniques that he's developed through the years and years he's been practicing that I never got to see when I was spending my time in Boston at the major university hospitals. Those little pearls are essential in really, really taking that pain care one level up. The other thing I wanted to say is that there's a lot of really exciting technologies out there, and we can get into some of those, but some of those are very innovative that have identified different ways in approaching pain that weren't available even 5-10 years ago. Yeah.
For example?
For example, ketamine infusions, for example, one has been around for a very long time. Ketamine itself has been around for a very long time. It's used a lot in the operating room. It's used a lot in inpatient, but now it's experiencing a pretty strong surge in the outpatient setting. It's
even being used in EMS now.
That's right. But to have tweaks to the ketamine treatments, such as what you experienced recently, that takes a little bit of synthesis of information. So that's one with medications, right? Because it deals with receptors like NMDA receptors. We have procedures now, for example, even in spinal cord stimulation, right? Which we've all heard about, putting an electrical wire near the spinal cord and trying to trick the impulse of pain from a certain level up to the brain. There's different modalities now where we can target certain nerve roots. There's different programming systems like Abbott system with burst, little micro burst energy bursts to kind of trick the nerve a certain way. There's even Boston Scientific's Dream Writer where it actually has this algorithm where it covers energy through a whole wide area on the spinal cord to even high frequency with another company, Nevro. So there's a lot of options. There's back then we thought about, if you're having back pain, we couldn't fix it with injections. We couldn't fix it with burning the nerves on the lateral sides of the bone on the spine. It was probably the discogenic pain. Until recently, there's a lot of information that's starting to come out that maybe it's not the disc, but maybe it's actually inflammation of the bones, the actual spinal column itself. Yeah. And there's a nerve in there called the basivertebral nerve, and there's some data that's coming out now where if you burn that nerve, patients do really well. So again, there's a lot of technologies coming out that warrants a longer, thoughtful discussion.
Yeah.
And there's minimally invasive procedures that are coming out where God bless spine and back surgeons. They do wonders. But for those patients that may not be excellent candidates or fear to go and experience open back surgery, well, now there's minimally invasive options to somewhat come close to dealing with some of the issues that present that in the past go to the spine and back surgeons, but now can be dealt with minimally invasively. So there's a lot of different things.
Yeah.
And there's medications.
Right.
We live next to Boston, next to Cambridge, where it's one of the biopharma meccas of the world, where there's a lot of new innovations that are coming out therapeutically.
Yeah. No, that's great. But by the way, you mentioned earlier, you were talking about pain management and pain patients kind of falling by the wayside or into the shadows. And I was reminded of something Jenny says a lot about, how, someone who's experiencing chronic pain, sometimes people have a hard time understanding that they're, that they're sick or because they don't look sick. I've heard you say that a lot. If someone doesn't look sick, it's hard for some people to comprehend that person actually is dealing with something. And maybe that's some of the stigma around pain patients, is a lot of people just out of, not that they mean to, but just out of ignorance, they don't think of that necessarily as a chronic illness or a condition. So.
Right.
Yeah.
That's true. When you were talking about the ketamine infusions, that is so state of the art that it's not something that's widespread all around the world. I know that when I did some research on to CRPS and RSD treatments in the Netherlands, the Dutch have a very extensive plan of care, and they've had it in place for over 5 years, which is really impressive. In the community of my disease, there's not a whole heck of a lot out there. But to my knowledge, you're one of only 2 in the entire state of New Hampshire offering the ketamine infusion treatment that, affords a person like me the ability to sit here and say, I'm not on any opioids and I don't take narcotics and I have this horrible disease, but I'm getting the management differently through this process. And I'd really love for you to talk about that. So people, I don't think, understand what a game changer this is in some cases, and especially for the New England area. There are no ketamine clinics in Maine. There are no ketamine clinics in Vermont. There are a few in Massachusetts, and like I said, to my knowledge, here in the great state of New Hampshire, I believe we have 2.
We have 2 with another center reopening or opening up. Correct. So there's actually going to be 3.
Okay.
I don't know if Dr. Sanchez wants to comment real quick before I add anything. Or?
No. The Dr. Ngo brought in one of the most exciting areas in pain management, which is all the different modalities of neuromodulation that I think are going to change the way that we treat pain. And, that is an area that Dr. Ngo is extremely proficient in. He trained in Boston, and he's an expert in neuromodulation. I look up to him. I really look up to him.
I'm sitting upright right here right now.
This is twice now I'm blushing on the show.
I really do. He did 3 neuromodulation procedures this morning, and I was helping him with the anesthesia, and I was just telling him on the way up, how proud I was to see him do these 3 procedures that
That's
were
awesome.
Very, very, very difficult, and he just.
That's 3 times now I'm blushing.
It is so awesome. I love my doctors.
Yeah.
Yes,
I love
yes.
my doctors.
Right.
I really do.
Right. So there's a lot of hope for chronic pain patients
Yeah.
in the future.
Yeah.
And there is also the advent of medications to treat pain with polypeptides that bind to certain receptors, and that is an area that is currently in tremendous development. And I think within 10 years we're going to see the treatment of pain in the brain through manipulation of some of those receptors with different polypeptides. So there is a lot of interesting and wonderful research coming up, and there's a lot of hope for patients in chronic pain.
Wow.
So that narcotics, they don't need to be used.
Wow.
So we'll see. I think we're in the next 10 years, we're going to see some wonderful developments in pain. Yeah.
Well, it's an amazing time to be alive, as far
is.
as medical technology, in general, always advancing. I just want to say hello to Tony Petrello and Mary LeMay and Wayne Noel, who all join us in the Facebook live chat. And if anyone has a question or a comment or anything to add to the discussion while the doctors are here with us, you can do so in the Facebook live chat or give us a call, 603-250-6007, 603-250-6007. Do you see a lot of patients at the practice who are in kind of who have found themselves in a situation like Jenny was in, where maybe they've been, like she was. I saw it. The way she was abandoned by her previous provider. I mean, do you encounter a lot of new patients who are kind of in that situation where they've been kind of abandoned and just sort of left on the side of the road, metaphorically, and they're kind of desperate, and do you see a lot of that?
Yeah. We don't really advertise or promote our practice. Our practice is basically a word of mouth.
Yeah, yeah.
And every day, I see patients 2 days a week. The other 3 days I do procedures. But the days that I see patients every week, I will see 1 or 2 patients with a history similar to Jenny.
Wow.
Where patients have been not abandoned, but they have been mistreated,
Yeah.
in my opinion.
Yeah.
And so it is, I think it is very common.
Yeah.
We have a practice of, we see, several thousand patients a year. And I would say that at least 1 out of 20 patients that comes to our practice has a history like that. So I would say that is significant.
Yeah. Yeah. It's and you hate to hear about that happening to people, but it's wonderful that they then find you gentlemen.
I know there are some efforts on the way, and we've spoke briefly about it before, in that the Senate in New Hampshire is trying to put forward legislation, Senator John Reagan, to try and help doctors treat their patients without as much, I don't want to say the word fear, but it's this logistic fear of the medical board smacking a doctor for prescribing what they say is inappropriate instead of going by individual patient. And I know that there's efforts along those lines.
You're right. And Jenny, thank you, because you have put me in touch with Senator Reagan, and we have been going back and forth on, the bill that he's proposing up in the capital for New Hampshire, wherever that is.
Concord.
There you go. I apologize. I'm still new to the area.
I
didn't even know where Manchester was. He had to drive.
Oh, really?
Your first year here, we acclimate you into this, and by next year, you're supposed to be at least in the minor leagues of our political sports spectrum.
Yes. Thank you.
Yes.
But I just want to say that, yes, it's very challenging for providers. And it's very challenging on many fronts is because, certain areas have patients that the way medicine was practiced had their pain dealt with one set of medications. And, as with many things in life, when you're exposed to one set or one type of medication, your body adjusts to it. And therefore, sometimes requiring more. When that occurs, there's always different issues that come to play. Not, and that's where, government starts becoming concerned because you start seeing the data out there where we're starting to have a lot of these complications. There's greater risks for self-harm. There's deaths. There's, suicides, overdoses. And that's when the feds have stepped in, and that's when, states have, tried to figure out ways to how do we deal with this. And then that's where there's a lot of pressure on physicians that prescribe, especially opioids.
Yeah.
I tell these to patients all the time because we're kind of in a bind where I attended a meeting in Washington, D.C. about maybe 4 months ago where one of the speakers in a room of about 300 pain doctors from across the nation, one of the speakers was from the DEA. And that gentleman came in and kind of, when he spoke, even though it was a short talk, the whole room was completely silent. You could slice the intensity with a butter knife.
Yeah.
And it's because everyone's scared.
Right.
Scared on many fronts. One, we're scared not only for the way we practice, but we're also scared for the patients because there's it's not just opioids, but now with this, for example, medical cannabis issue. Mm-hmm. And I tell patients this all the time, that one of the concerns I have is, yes, you're on opioids, and I'm happy that things are working for you. And when they, some patients request, well, I'd like to augment that with medical cannabis. That, again, there are very, very viable merits to certain elements of medical cannabis. But the problem is that with opioids, if we administer it to you legally, we have a way of controlling that consumption or that use of it in some manner.
Yeah.
Whereas if we sign off on the medical cannabis, form, we don't really have much of a way to help monitor or guide or even shape the use of those elements.
Yeah.
And those things are concerning because when you're in pain and pain is real, you try to do whatever it takes to decrease the pain and suffering.
Oh, of course.
And
yeah.
so it puts everybody in a hard spot. And that's why when you're saying those kind of things, it's true. It's how do we deal with these things safely, but in a way where it's safe for not just patients and providers, but for everybody.
I would love
out
to
there.
see medical cannabis go in the way that the Netherlands has, in which when a doctor warrants that it's for the right choice for that patient, the doctor actually chooses the strain that he wants the patient to have and the dosage. So, for example, they may say that they want them to have an indica strain because it's more of a muscle relaxant, and they want them to have 5 grams a day. That is what would go out. And the pharmacist is who actually gives the prescription to the patient exactly to the doctor's prescribed choice. And here in New Hampshire, medical cannabis is part way there, but not all the way there it should be. But we have these dispensaries, and they're not using doctors. In fact, I know one of the dispensaries refused to allow doctors to come in and see how they were doing the products. And that's just, it's absolutely ridiculous.
Yeah.
Matt, I know you're making you remember I told you about that?
Yeah. Oh, yeah.
Yeah, and it's ridiculous because if you're really a dispensary that's out there for helping patients, don't you want the doctors in there knowing what you have and knowing how things could work or not work? So I can understand what you're saying. And from a patient perspective, you don't want to get your doctors in trouble.
Right.
But you don't want to suffer either.
Right.
So you kind of end up stuck in a catch-22 on your own of what do I do? I'm kind of lucky in that I would carry around the white cane so everybody knows I don't drive. So it puts me in a little different of a category, but not much, not much.
Yeah.
You have to be concerned about what happens when a patient leaves the room. Are they getting behind the wheel? I remember when I worked in EMS, if there was an ER patient that had been given a med, we would legit walk them out and make sure that we handed them to somebody else who was driving. We didn't take their word for it. We had to hand them off to somebody because the risk for us as an ER was humongous if that person got behind the wheel and then they take out a family on the way home. So it's more than just, it's not, I guess I want to share that because I don't want people looking at it and going, oh, the doctors just don't want to sign off. When it's not that. It's really about making sure that the care is going to be the right care.
Yep. And I agree. I always want to comment. One of the reasons why I really love working with Dr. Sanchez and the team that we have in our office is that, and by the way, shout out to the team in the office because they're probably listening right now.
They probably, hopefully they are.
I love your office staff. Let me tell you, I love this office staff. They are so happy and so chipper. And one of the nurses, I'm sitting there like nervous as heck, is you're about to do a block on me. And there's this wonderful nurse who loves the color purple. It's my favorite color. And she is so happy and cheerful that you can't be nervous around her. She just keeps you in a better place. And God love your staff. I don't know how you managed it, but don't you get rid of every one of them are amazing.
Yeah.
I just showed up one day and they were there. It's all about Dr. Sanchez did it.
Okay. All right. Yeah.
But that's important. It's really important. I mean, I've had a doctor in an office that I loved, but I hated the staff. Because the nurse was like so close to me in the bathroom. It's like, do you want to wipe me too? Because she's that close to me. Not to sound crude, but that's how it kind of was. Your staff is, of course, nowhere like that. But it matters to have great support staff to have a good doctor.
But Jenny, so thank you for those kind comments about our office. I'm sure the staff really appreciates it.
PainSpecialtyGroup.com.
Oh my goodness. I do want to say though is that I think the philosophy in our office really percolates out, and that philosophy is that we understand life as a journey, and we understand that when you're suffering or when you're happy, it's part of that journey, and our goal really is just to help you get through that journey in a way where you can continue your travels in a more fulfilling, more complete way, and because along the journey we're going to have things that strike you down, make you fall, make you limp, make you feel like you can't go on anymore, and that's basically all our real philosophy. And I think Dr. Sanchez can comment on that. But
yes, we do.
Yeah.
Yes, we do. Yeah. And this, I think the reason that we can do that for our patients is that, we are our own bosses. We're not part of any large hospital organization, so we don't have to. We don't have to respond to the wishes of a medical board.
Can I just say one thing? If my wife's listening, I'm kind of like my own boss, but you're really the boss. Go ahead. I didn't mean to interrupt.
Right.
Nice save.
Well done, sir. Well
Thank you,
done.
sir.
Yes.
Thank you.
Yes.
She may be watching me now too.
Right.
So the fact that we're our own bosses kind of allow us to do what our philosophy is all about. And there's some wonderful doctors in the area, but they cannot do it because they have to be, they have to be accountable to the CEO, to the board of directors of the hospital.
It's about the numbers.
And when you're in that situation, really the bottom line is dollars and cents.
Yeah.
And the cost of healthcare is prohibitive, is just out of control, and hospitals and government institutions have to produce to stay in business. We are fortunate that we are independent, and we're not greedy. We love people, we love our patients, and we're happy to make a good living.
Yeah.
And and I think that is the philosophy that has been very effective, at least for me, for the last 30 years.
For the short time that I've been a patient, I've noticed that one of the things I think is great that you both offer is you're learned in diseases of rare disorders. Like I said, what I have wrong, CRPS is rare. And a lot of patients go through 8 doctors before they get a diagnosis. Or in my case, where I have a diagnosis and other things get missed because they look at the big one, but they're not looking at anything underneath. You guys have the wherewithal and the education and the ability to look at a patient in totality and see that. But I really want to push the fact that about the specialties, because that is something for me that's huge. And we all need to get that information out there that you exist, that people can come and get good quality care for their pain. They're going to be treated as a human being in a humane way, and that things don't get missed. I'm not saying, nobody's perfect, nothing like that, but you've looked at me as a patient in totality, not a number on the screen, not 15 minutes and leave, but in doing so have found ways to help me that I never had afforded to me. And I've spent over a year of crying, this hurts really bad, and I don't know why I have to sit down in the middle of the street every time this happens. In 5 minutes, you found that. And I just want every pain patient to have the chance to be seen by somebody of quality. It kills me. I'm gonna get emotional, but when that office closed down and I was faced with no care and not knowing what to do, there were so many other people that were terrified because they were patients too, and nobody knew what to do. And when we asked them, what do we do? The answer we got was, go see your primary, who doesn't know anything about your disease and doesn't know how to treat you, and basically pass the buck. That it's so important. And I hope that you guys are an example that other doctors around here look up to and realize that narrative medicine and quality medicine needs to be in every New Hampshire practice. And no patient with a disease like mine, that 70% of people with it will actually contemplate killing themselves, has to go through that suffering, because it's wrong. And I'm going to get angry too. It's wrong because we're suffering, and you're getting stranglehold by the governments and the powers that be and conquered, trying to tell you how to take care of your patient. And that's why we need more attention on this, because I want to live, and there's a lot of people out there that want to live, and we shouldn't have to be treated like criminals because something bad happened to us. I got breast cancer. How many of you out there know somebody with breast cancer? I could be them. They could be me. So, please talk about this in your dinners. Talk about it at home. Be open about it. We need to be open about it. Pain matters. It's not something to go, come on, suck it up. You can take it. Because it's not. And pain doesn't take a break. Like a torturer takes a break. I can beat you, but I'm going to take a break and go to the bathroom. Pain does not ever take a break. People who go through torture have more rights or less suffering than people who have chronic illness.
Yeah, Jenny.
Sorry.
It's okay, Jenny. Thank you. For,
I knew that might happen.
It's okay. I just want to say one thing. I know you refer yourself as a patient, right? Because you're going to a clinic. If I go to Best Buy, I'm a customer. But the truth is, and I really believe this, and I hope it propagates through the history of our practice, is that that individual that walks in, they're not a patient just because they walk in a clinic. You're not a customer just because you walked into Best Buy, and you're not a diner because you walk into the restaurant. We're all people, and again, I'm gonna just highlight again is that we're all going through life in a journey, and we're all gonna help each other, through that journey, and hopefully, one day, you'll help me on something that I need for some whatever reason on my journey. But as of now, we're happy to help you with your journey. Okay, yeah. And I hope that applies to everyone out there that's thinking of things that are affecting their journey. We're here to help.
Yeah,
and we're here to help, and we'll work with you if things are difficult financially, and that's what we've done with a lot of our patients in the clinic. When the holidays came, and
that's huge,
and they wanted to spend money on their grandchildren. Dr. Sanchez and I were like, we'll just figure it out. Just don't worry.
Yeah.
And I it's because life is a journey. We're people.
Yeah. No, that's
you have any idea
wonderful.
how many doctors, unfortunately, there are out there that, you don't have money? No med. Forget it. We're not going to treat you.
Yeah.
That's like looking at a diabetic and going, oh, no insulin. Oh, wait, we do that. That's right. Our insulin prices are through the roof.
Right.
So this goes right back to what we were saying before about government getting in the way. Look at that happens every time they do something.
And part of that too, as Dr. Sanchez was mentioning, is a lot of these doctors are working for these, they're these big companies that own these clinics where it's all about the numbers and it's all about how many. I think you said, some of them are seeing 30 to 40 patients a day, and I mean, I'm not good at math, but that sounds to me like they're hustling people through pretty quick if that's what's happening. Yeah.
You have to.
Yeah.
You have to. Yeah. It is impossible to elicit a proper history and to learn about the psychosocial issues that are afflicting your patient.
Yeah.
And examine them and look at imaging studies, lab studies, and establish a plan of care in 15 minutes. It is impossible. You cannot do it.
Yeah.
You cannot do it.
And by the way, that's one of the reasons why we run late a lot too. It's because we spend more than what the allotted time in our clinic with patients, just because everybody has a story, and if you need a little more time for your story, so we can kind of get the better gist of it. No,
I've seen too, with Jenny, after a treatment, you make sure she has plenty of time to recover because it's,
Yeah, that's a change.
Yeah.
That's a change from unhook her, flip her over, then he shove her in the car. She's still puking. That's okay.
Right.
We no lie, this really happened. They're pushing me down the hall in the wheelchair and I'm actively puking.
Oh, God.
Like all the way out to the car. And it's like, yep, there you go, take her home. And he's like, oh, what do I do with this? Because no offense to anybody. I mean, I may have a medical background, but Matt does not. He does not handle these kind of things easily. He does, but he doesn't. But it's not easy.
It's fine.
I'm sure you appreciate me not getting tossed into the car while still puking, right?
Yeah. Well, I mean, just as kind of a general rule, I prefer you not puking.
Yeah.
In any scenario, like I'm kind of like a non.
You didn't like the whole exorcist look I had going?
No.
No?
I'm like a non-puke kind of guy.
Yeah, I was definitely looking
Myself.
like a horror movie in the past. That's for sure.
Yeah.
I don't know many puke kind of guys, so I agree with you about
Yeah.
non-puke kind of
Yeah.
No, not turn on, huh? Yeah.
No. Yeah, I'm very non-puke. Yeah.
Yeah, but you know what? We solved that problem with me just by you changing up a couple of things, by treating me as an individual patient
that's true.
instead of okay, here's the box, fit yourself into. This is what we give you for treatment. These are the guidelines, and we're not going outside our little box. Everything's been to me all the way. And I remember after the first treatment, you were like, "Oh, I know why this didn't work because I gave you this, and they gave you A." I'm like, "Oh, well, that's a good explanation as to why I was terrified," among other things, because this treatment's not easy. Ketamine infusions aren't easy to go through. It's like lifelong chemo, and I lose 24 hours of my life. I can't remember, and that can be very unnerving. So that's where trust comes in big time. Because I being able to trust you to put me to sleep, and I'm going to wake up and be taken care of, and I don't know, I'm not going to remember any of it until far later into the day, is a huge scary thing to do. I thought getting needles in my spine was scary, not even close to being put to sleep. So, but now, I have a comfort level that I'm like, I'm good. I'm getting put to, it's like going in and have my uncles take care of me. I'm serious with these two doctors. It's literally like having your uncles come tuck you in. So I'm that safe and that happy.
Yeah.
But I was absolutely terrified of going to a different facility for that exact reason, because I was terrified of letting them put me to sleep.
Yeah.
And you remember that. I was like I need to write the letter of the just in case I don't wake up letter. Like, I've literally been that afraid. And I'm sure you can understand that as anesthesiologists, you both have put tons of people to sleep. And I'm sure you've seen every type of fear right before you do that. Mm-hmm. And it's a huge to put yourself in somebody else's hands and go, okay, you're going to take over watching sure that I'm breathing okay, that my heart's okay. That's huge. We have
a call. We'll get this caller back in before we have to adjourn at the top of the hour. Hi, welcome to Matt Connarton Unleashed. Who's this?
Hey, Matt, it's Mike Doyle.
Hey, Mike Doyle. How are you, sir?
How you doing? Happy New Year to you and Jen and the doctors there. Hey, great show. Great topics. I had I had actually two questions.
Yes.
Two-part, and I'll hang up and listen because I'm really enjoying the doctors here. One is, do they think the level of care is based on strictly numbers, where some doctors just want to move through as many as they can, where they would probably choose to take longer time, but it's a numbers thing. And then the second part of my question was, maybe they could shed some light on what they both came from Canada, I heard in their introduction. And so maybe they could shed a little light on the Canadian health system and how it, compared to the United States health system, I guess would probably be the easiest way to because people right now, there's some candidates talking about socialized medicine and trying to match Canada and some other countries. And I wonder what, both of them having knowledge of both the doctor and coming from there would probably have a good aspect of that. And I'm going to hang up and listen, and great show.
All right.
Thank you.
Thanks for the questions, Mike. Thank you. Bye-bye.
Thanks.
So let me tell you about the Canadian system. The reason I came here to the United States 30 years ago was because of the socialized medicine that exists in Canada. Socialized medicine was established in Canada in 1967. The government passed what is called the Canada Health Act that assured the citizens of the country to providing with health care. And it made it a crime to provide any medical services by any physician outside of what the government solutions were for healthcare.
Really?
Wow, I didn't hear that.
So that system existed for, a long, long time, since 1967 until at least 1988, which is when I left Canada. And let me just give you an example. Southern Ontario is an area of Canada with a population of about 2 million people. There were only 2 MRIs for the entire Southern Ontario. One of them was in Toronto, the other one was in London, Ontario. And these were MRIs that were working around the clock, day and night. The waiting list to get into one of those MRIs was, you have to wait sometimes months to have an MRI. I had some medical issues, I had some back issues, and I needed to have an MRI, which I could not get because it was impossible. I did not meet the criteria that the government had established for an MRI, only because the demand was such a huge demand. So that kind of, put a bright light in my brain and told me that, this is not good news.
Right.
Eventually that system kind of burnt out itself, and the government began to change the stance to the point that now there are private practices and private insurances where you have to pay and I feel like you pay here and then you are seeing at one of those private clinics.
Yeah.
And those private clinics are flourishing. I know that because, all my friends that I left in the medical community, they all eventually became part of that.
Oh, okay.
Because the government had a very tight rein on physician income, and that is what they're proposing here, to have a one-payer system. To me, that is one of the most stupid ideas how to deal with healthcare. Because even with the system that they have now, where they have those clinics open, if you have a heart attack and you need a valve replacement, you might have trouble at the end of the year finding out a hospital that has a valve or that has a new valve replacement, or that has the equipment that is needed for you to have a bypass surgery, because each hospital has only an X number of valves, X number of all the equipment that is needed for this, whether it's for a heart replacement, for a heart transplant, for a valve replacement, for a new hip. So the waiting lists are still a long, long way.
Wow.
So that's what they're
intense.
looking at doing here. To me, that's crazy.
That's
That's crazy. The same thing happened in England 50 years ago, and they're switching over. They're abandoning that system.
Yeah.
I don't know why they.
Right. Okay. Here, let's. We'll grab this one last call before you gentlemen have to go. Hi, welcome to Matt Connarton Unleashed. Who's this?
Hey, Matt, it's Chris James calling from Canada.
Oh, our friend Chris. He actually lives in Vancouver.
Oh, my goodness.
Yeah.
Be nice.
Yeah, I live in Canada, and I'm very interested that you have somebody on here who is speaking this way. I'm curious why, Matt, you have this person on, and to what end, and what it is, the message that you're trying to get out here.
Well,
and I'm curious. I just caught in the middle of it. This gentleman is a medical professional. Is he from Canada?
Yes.
Just fill me in, please.
So both of us are from Canada. I'm also Canadian. It just happened that we have a Canadian contingency tonight.
And they're my doctors.
Yeah.
And they're taking care of me with a very rare disease that I have.
Yeah, these fine gentlemen here. That wasn't the main topic. Mike Doyle did call with a question about Canadian healthcare, but they're actually they're pain specialists who've been helping Jenny with what she deals with, and that's really been the main topic is pain management.
I just jumped into the middle of a conversation as some guys talking about how the Canadian healthcare system is so bad and how the American system is trying to move to that, or these people on the left are, and that's a negative thing altogether.
Yeah,
I think it's a more nuanced subject matter than this gentleman is making it out to be.
Well,
I think that he's speaking, specifically in regards to the stuff that he specializes in, and seems to me like he's potentially discounting care for more common care that is covered and discount. I'm looking at his face right now too. I'm seeing how he's reacting to it, and it's making me laugh.
I'm thinking, Chris, you don't have a heck of a lot of experience with some serious illnesses, because if all you've ever had is a sprained knee or an ankle, I can understand why you don't know that kind of care stinks and is being rationed.
Yeah, Chris, actually, just to come in, Dr. Sanchez's defense, it's like you walk into a conversation about walking the dog, right? You walk into a conversation about,
This is boring already. The thing you're saying is boring.
Yeah. It's boring. But what I'm saying is that
you're
getting a slice of the conversation where all of a sudden you hear certain buzzwords and it makes your ears perk.
Of all days, it had to be
Yeah.
today. All days.
No, we were
You're
talking.
calling today, Chris.
We were talking about the care of pain patients in New Hampshire. It just happened that the Canadian question came up.
And in that case, I will step back and I will say, because if it's to do with care for Jen, I like Jen a lot, and I hope that Jen gets the best care.
Thank you.
And I really genuinely mean that.
Dude, these guys saved my life.
Is the truth.
Hands down, not kidding you.
I stepped into the middle of a conversation where I was listening to my friend's show, and I was hearing my healthcare system being questioned, and I was thinking, well, wait a second.
But
I don't know what the positive aspects of that are.
But Chris,
right now,
just we do take Canadian patients. So if you want to come over, we'll take care of you.
Oh, very nice.
Yes. I love this.
Very nice. There you go, Chris.
Sorry. What did the little weird boring guy say?
Oh
didn't say that.
Chris.
Oh.
Be nice.
I don't want to get help from
He
it.
said-
I don't need. I
he
don't
said
need
that he'd be happy
support.
to take
I'm
care of
telling you
Canadian
personally, my
patients.
experience with the Canadian healthcare system is that I have had issues. I've had significant, not necessarily life-threatening, but I've had significant issues, and I've never paid anything for it, and I've never had to wait,
your sign.
and I've always had myself cared for wonderfully.
Actually, you have paid in the form of taxes. There's nothing free in this
Yes,
world,
yeah,
my
That's
friend.
right.
Oh. Of course I have, you goon. You're such a honestly, I can't handle this anymore.
Breathe, you.
All right, Chris. Thank you for the call.
Hold on. You have to explain this. You have to explain this, or I'm going to be like walking into their office red-faced forever.
Right.
So please tell them what happened.
So Chris James is a comedian from Vancouver. He hosts a show. He has a show on YouTube called Not Even a Show. And he calls these different shows, and he calls my show. He's actually a great guy.
He actually pranked this show for about a year before Matt knew it.
No,
he was calling in and prank calling him, and he had no idea that the guy was like recording it and turning it into his own show.
Yeah. It's a lot to get into, but
But of all days,
we
you
won't
call
get.
it
But
today,
of,
buddy.
of all days, Chris calls today. No, but no, he's a great guy. But I think he got the impression that was like the main topic when actually it was a sidebar. It's really Mike Doyle's fault, the previous caller. So we're gonna blame Mike Doyle.
We'll still take care of him too.
Yes.
Yes,
No,
yes.
I know. And
They're equal opportunity. They all are welcome.
And I'm kidding about blaming Mike Doyle. But
He gives a good needle.
right.
You know, 24 gauge in the hand, very nice.
Right. Yes.
People in EMS understand what I just said, mister. I see the smile in the corner of your mouth.
No, I understand what you meant because you explained it to me before. But that's all I know about medical stuff is
Can you read my sign
what I
language?
learned from you. And that's all I know.
If you ever listened to me, that would be another story, mister. I'm having an asthma attack. Oh, no, it's just a cold. Dude, you can't breathe. You need to go to the hospital. No, it's just a cold.
I did almost die
He did.
on
He
the
literally did. No,
the
this is a
lawn
real
of-
deal.
on the front lawn of Catholic Medical Center. But that's another story. We don't need to get into all that. But well, gentlemen, it's just after 5, and I know we need to wrap up with you both. But before we do that, before you have to go, is there anything you want to make sure that people know about? Is there anything we didn't touch on or about pain care and whatnot? I don't know if
I just want to say that.
Go ahead.
I just want to say that we're very honored to be here, and thank you for giving us this opportunity to be able to speak on some of
Actually,
these
we
topics.
hope you guys will come back.
We would be
I'd
honored.
love
Yeah.
to see
Sure
more.
we will.
That would be wonderful
sure
to
we
have
will.
you guys back to talk about pain care. It's such a huge issue now. I don't know anybody who isn't affected by it in one way or another.
yeah.
And people need to know. The more knowledge the people are, the better. I believe the better you are able to get access care.
Yes.
The more power and information. I can't spit it out. Chemo brain.
Yeah. Well, Jenny, I just want to thank you because you are certainly an advocate for people with chronic pain. And the people in this part of the world need somebody like you.
Oh.
They do. They need somebody
Start
like
crying
you.
again.
Because that is what brings in change. That activism is what brings in change. And that is something that is very badly needed right now.
Comes
in
from
this
a real
area of pain.
place.
So
I don't want to. Thank you.
Thank you for being an advocate.
No, in seriousness, I've lost, and Matt knows it. He's seen it happen. I've lost people. I've lost friends with this disease to suicide.
Yeah.
Because they couldn't handle the pain anymore, and there's no real great way of explaining to you what that pain feels like, but you guys provide hope and control the burn, control the pain that we suffer from, and that's what gives us the ability to still have a good life. I still have things to offer this world. Just because I'm not an EMS anymore and I can't do that doesn't mean that I can't do something good. And you guys help me do that. We need more of that. And we need more people talking openly about pain care because it's in the closet and you're not talking about it. You don't want anybody to know that you're in treatment. That goes along with it too. I have a therapist. I tell everybody I have a therapist. I keep her in my back pocket and I take her out every time I need a tune-up. We need to talk about these things and have an open dialogue if we're going to save lives and change lives. And I don't want to see any moms or dads out there losing their lives or their children losing their lives to pain that's not controlled or their they're going to the street or whatever they're doing, more people that are in good quality doctor office visits are going to have that pain control, and they get to live longer and make a difference in our lives. You never know what that's going to be, right place, wrong time. You never know.
Right. Absolutely. Gentlemen, thank you so much, Dr. No and Dr. Sanchez. It's been wonderful to have you here today.
Thank you.
And when this goes up and it's available online, we'll share it out everywhere. And I think it was a great conversation. And thank you so much for what you've done for Jenny. That's been amazing to see. And watching what she went through when the other practice closed and whatnot, it was very, very tough. And so I appreciate it so much.
Thank you.
I appreciate you both. And
we're honored. We're very honored.
Oh, well, thank you.